Okay. Welcome everyone to Artist Learning Lounge. Today's discussion is on rehabilitation services for people living with dementia. As you may know, the artist philosophy is about, is about human care versus memory care. We had a little bit of technical difficulties, I'm sorry. Today, we are going to dive right into how you see a person struggling with cognitive impairment, how to relate to them, and learn what their cognitive understanding might be when going through rehabilitation. I would now like to introduce our speaker, Vivian Green-Horner. For the past 25 years, she has dedicated her career to enhancing the lives of individuals challenged with Alzheimer's disease and offering much needed support and guidance to their caregivers. Vivian has an active private practice focusing on family caregiver issues. In addition, she provides dementia care training seminars to home health professionals throughout New Jersey. She is a caregiver support group facilitator, serves as a guest speaker for the community groups, and offers presentations on caregiver issues. Vivian's commitment to raising Alzheimer's awareness has led her to create and organize 7 community-based Alzheimer's awareness weeks in communities throughout New Jersey. She currently holds positions in county and hospital advisory boards. Vivian holds a master's degree from New York University and is certified as a dementia practitioner. Prior to her current work, she was director of the Kaplan Adult Research Center, a social adult daycare program for 17 years. Vivian, we are so happy and really excited to have you here with us this morning. Welcome.
Thank you. Joyce, I don't see the slides. Are you going to be putting them up?
Can you see them now?
Yes.
Wonderful.
So good morning and thank you, Joyce, for that introduction. I support the dementia community. As Joyce says, I have a private practice in which I offer advice and guidance and resources to caregivers. My work is directly with family caregivers. And the whole idea of working in rehab services is very near and dear to me. I was in PT for an injury I had doing yoga. I value PT, but I also came into PT with the perspective, if I had dementia, how would the physical therapist have to work with me differently? So I was very cognizant of that. And it was a very eye-opening experience for me. So with that, I want to share with you what to consider in working with an individual with cognitive impairment so that you have a successful outcome. So I'm going to be sharing, and for some of you, it might be a revisiting as to what do you need to consider when working with your client or patient who has cognitive impairment. So the outcome objectives today will be to review the impact that dementia has on the individual, working with the secondary effects that dementia has on the individual, and finally, the considerations for you to have to improve on your treatment outcomes. Joyce, you want to move? So, Here's the individual who has cognitive impairment. You're going in to offer your services. This is not just your ornery older adult. Consider that this person has, oops, we're moving
Oop,
ahead. Let's go back to the photo.
sorry.
That's
There we
no
go.
problem. There you go. Consider that this person has a form of dementia, whether it's Alzheimer's or vascular or Lewy body or frontal lobe. That cane is now a weapon. Might never have been a cane to them because of their dementia, that they didn't even know what that cane was for. But thank God that cane's there because it's a weapon now. Because who are you? Even if they've seen you in previous therapy sessions, they have no recall of the past, even if it was yesterday or the day before. Um, they don't know who you are. They don't know why you want to do something with them. And it's kind of a fight or flight. That cane is back off. Again, we're going to break it down as to why they might be feeling this way about you, who they consider to be a stranger and maybe harmful. Next slide. So idea of what is going on, what is memory loss. You'll see on the left side, the normal, very full brain. And on the right side, I say Alzheimer's, but again, it could be a vascular dementia, a Lewy body. But the difference you'll see is that the normal brain is larger, it's fuller, because the brain cells have died to the Alzheimer's brain. It's smaller in size and it has shrunk their crevices also. So that area of the hippocampus, which is that area of the brain which you store information from your five senses. Once you store it, you can retrieve it. That area is shrunk, so there isn't a place in the brain tissue for them to store the information. If you can't store it, you can't retrieve it. So they don't have the memory. They don't have the short-term memory. They're not going to remember that they had a session the day before. They're not going to remember the purpose of the session. They're not going to remember who you are. You might just be a nice-looking person with a nice smile on your face, but you need to understand that they don't have that recall. Next slide. So whether again it's Alzheimer's or vascular or the other dementias, here are some common symptoms. As I mentioned, they're not going to have the ability to remember that information. They lose their ability to use words. So that cane then becomes that thing. The person who is familiar, they're going to forget their name. That person becomes a nice girl, but they're not going to remember specifically that person's name. It's very common to lose words. And one word eventually, as the disease progresses, can represent everything. So for instance, somebody who only says now ice cream, I want ice cream might mean I want to go to the bathroom. They're using the word ice cream. Or if I don't like ice cream, it might mean they don't like the music that's going on, or they don't like the extraneous noise going on. They lose their ability to use words. They lose their ability to interpret or understand what's being said. So if you say, raise your arm, they hear it, but they don't understand what you mean by that anymore. So you might think that being oppositional, or maybe there's a hearing problem. When we're talking about the dementias, and obviously it'll be on your chart, keep in mind that they might not be able to understand what you are saying. one of the areas that gets attacked is the frontal lobe. That's that area that allows them to control their impulses, their area to reason and be rational. So with that ability or disability to control, understand what's going on, they might be fast to lose their ability to control their impulses, control their temper. They might really flash from being agreeable to being disagreeable. Might be because they don't understand what's going on in part, and it might be also because they've lost that control that's offered in their frontal lobe. They lose their ability to perform purposeful acts. An example might be to button their shirt or their sweater. They see the button, they might feel the buttonhole, but the idea of putting the button through the buttonhole, they might see their socks, they might feel cold, and you might give them a sweater, but to remember to put their arm through the sleeve, put their sweater on, isn't available to them because they have this brain disease. And finally, it's so common for them to become disoriented. So even if they're going from their bedroom, familiar in their home, to their living room, they can be disoriented. And certainly you can expect that they can be disoriented if they're in a facility going from their patient room to maybe the room where you do your uh, uh, rehab services. That alone disorients them and can add to their confusion. Next slide. So we can understand from what I just mentioned in terms of the effect the dementia has on their brain, that they're so often confused.
Oh, you're gonna really.
We want to continue to mute for our attendees. Um, and in addition to being confused, boy, that's not who I've been. I've never been confused. So there's going to be a loss of confidence. That's not who I was as a person. I always was on top of my game. I knew where I was. I knew what I was doing. So often they're going to be less confident. As I mentioned with that photo, they're going to be skeptic, like, why are you here? What are you doing? There is no recall. So there's understandable skepticism that they're going to have, and a negative reaction. If they are confused and they are disoriented, there's going to be a chance their initial reaction is going to be a no. No to anything that you're going to offer them to do that you know will be something that will be a benefit, but they just don't understand what this is all about. And the knee-jerk reaction, because of the cognitive impairment in the frontal lobe, is going to be a no. We can also understand that there's going to be fear and anxiety, often because they're not sure as to what is going on and what the purpose is and what you want to accomplish and what they're supposed to do in part with what you are suggesting. For many people with dementia, there is depression. There is a loss that is going on. There's a sense of loss of their understanding, a sense of loss of their ability, loss of how they saw themselves. It is often a very sad time for them. They're feeling disconnected and isolated, and sadness can often morph into depression that so frequently I have with my clients. They are receiving medication for depression. And finally, delusions and hallucinations, especially with Lewy body, you're going to get hallucinations, seeing children in the room, often animals or insects in the room, and delusions, mostly paranoia. Paranoia because if they have misplaced things and they can't find things that are important to them, they've never misplaced things. So you are the one. They are going to be paranoid. People are stealing from them because they've always been able to take care of themselves. They've been able to put the checkbook where they thought the check should be, their wallet, their earrings. And the fact that they can't find them goes back to how they saw themselves. And so misplacing things, not finding things, they're going to blame somebody else, and they're going to have delusions about that. Next slide. So the accommodations that we have to consider first and foremost is to be extremely supportive with kindness. We really have to take into consideration all that I just mentioned. Um, when you are working with somebody who has a form of dementia, you will always need to reintroduce yourself by your name, why you are there, to help them in what way. All of this to orient themselves has to be presented every single time you meet with them. Um, so what you are doing, offering a tremendous amount of praise with everything they do. You stop, you praise, you introduce something new, you stop, you praise. Because of the dementia, their processing speed is slower. What you say to them, you might see kind of as a blank look on their face. Give them time, because it will take them longer to process what it is that you want them to do. So keep in mind that the processing speed is slower. In addition, with dementias, their visual field becomes restricted. So what you assume they see, their visual field with dementia becomes restricted. So with that in mind, anything that you are going to ask them to do, which is beyond this field, you need to have them look up to something that you want, or look down to something, or beyond this visual. Don't assume that they see the range that you see, because that alone can make them feel fearful and anxious if you are touching them in an area that they don't see. So for instance, if it's their leg, you need to tell them, look down at your leg, this is what I'm going to do. Directives have to be step by step. You can't say, lift and bend your leg. Raise your arm. I don't do rehab, so please excuse me. But you raise your arm and clench your fist. Two steps can't be done. It's raise your arm, clench your fist, and that's slow in terms of your communication. They can't do a two-step process. You always want
I'm
to
sorry.
be,
Sorry, I wanted to explain. Does anyone have any questions about what Vivian just demonstrated? Okay, I just want to make sure. Okay, Vivian, go ahead.
you always want to communicate anything in front of them. If you communicate behind them, they're not able to interpret you, and it can be just noise in the background. It goes with the visual field. You need to do all of your communications in front of them, and preferably at eye level, which means sitting next to them so that it's at eye level, or you need to stoop down. We don't want it to be that they're having to look up at you. It's too challenging to look up and listen. We need to accommodate and make it more user friendly for them. Keep it at eye level, keep it in front of them. And what I call show, don't tell. Remember the game show and tell? For them, it might be easier to show them rather than tell them. I'll give you an example. It's not a rehab example, but if you say, for instance, it's time to take your medication, and you give them the cup and the pill, they heard it, but take your medication doesn't necessarily compute for them. They see the glass of water, the cup of water, and they see the pill, but they don't know what that means. Take your medication. Better that you literally show them pill in the mouth, as a, you're improvising. Take your medication. That's show rather than tell. So accommodate that to how you practice, but often showing them rather than verbally telling them will be more successful if you are telling them and they're not responding. Try showing it to them. And finally, and most importantly, because they don't have a history of what might have been done before, or a sense of purpose of rehab, the rehab service, they are not looking at positive outcome. When I went into rehab service for my shoulder injury, I knew that I had injured my shoulder in yoga. I knew from that it was hard for me and I felt pain. And I made the appointment. I was told that rehab service PT was going to help me. So when I went into PT, the exercises, I understood why I was doing it for the positive outcome. I knew all of those steps. That process that I just mentioned does not apply to somebody with dementia. They'll feel pain. They will have no recall as to what happened that created that pain. So we can't rely on that. They don't know why. They'll feel it, but they don't understand the why part. And with such, let's go back again. With such, they're not going to be looking to what you're offering to give them positive outcome. The way to engage is give them a positive experience. Don't talk about outcome, how it's going to be helpful. Just give them that one directive as a positive. How is that feeling? Are you feeling more comfortable with that? Let me know if it's feeling uncomfortable. The focus is not on outcome, it's on the experience. And we can talk about that if you have any questions.
And yeah, just again, does anyone have any questions? Put me in the chat. I don't see any. Okay. go to the next slide then.
So as I mentioned, as the objective, when you are going towards improving treatment outcomes, the first is that you want to make it patient-centered, but with personalized engagement. What does that mean, personalized engagement? With the individual who has dementia, I know you're probably all trying to develop trust in your relationship, but this goes beyond what I'll say typical approaches towards trust. To trust from the person who has dementia, from their perspective, you really need to engage them personally, and take the time in a personal way. So if they're in front of you, you need to comment about something about them. Oh, you have beautiful eyes. That's personal. I really love that color sweater you're wearing. It's so pretty on you. That's the kind of trust that needs to be first and foremost put out there to engage the person. They have to feel that you're not a stranger, but somebody that they feel comfortable with. And I ask you to share something that I don't want to say is more of a personal, we're not talking about share your confidential, but share something about you. Oh, I love that color. Do you think that color would look good on me? I've never owned something in that kind of burnt orange color. You need to initially spend time, more time with somebody with dementia in terms of engaging them in a personal way. Take your time before you offer any of your treatment services. So the focus on developing trust is huge, more so than somebody who might not be part of the dementia community per se. When you are working with that individual, it would be best if you can ask them in any movement that they're doing to think about it with something that's familiar. And again, you're going to have to find out, for instance, was this somebody who loved to cook? Please excuse me if I'm not a trained in rehab services, but from the layperson's perspective, if you want them to move their arm, it's not just moving it, it has to be maybe stirring. If you want them to raise their arm, it might be catching that fly ball, but you can't just give them something that won't make sense to them from their history. So you need to find out a little bit more about their history, so that you can use objects that will be familiar with them, because it's the objects. It's not just rolling your shoulder, but for a purpose that's familiar to them. And if you have questions, we can talk at the end about that. With older adults, it's important to try to be in a place that you're working, eliminating extraneous stimulation, but this is extremely important for somebody with dementia, because it's not that they will get distracted, they really can't differentiate between the stimulation in the room. So you want to have your services where there are no other people in the room, if that's possible, because it's too confusing, as I mentioned earlier. We want to eliminate anything that's going to add to their confusion. So best to keep it where it's a one-on-one, just you and that person in a place that they feel is familiar, and with eliminating any extraneous noise or visual stimulation, you're best to achieve the outcome that you are looking for. So at this point, I'm going to stop, and I hope that there will be some questions that you have for me now. But going forward, Joyce put my information up. If you need more information, if you know of families that could benefit from my services, again, it's providing advice and guidance and resources to families both who live locally or who don't live in the area. I become the boots on the ground for them. I've been doing this, as Joyce said, for many years, and it's fortunate for me. I have a lot of contacts, which I can just pick up the phone. If I don't know the answer, I will find that out for you. But there you have my information. But at this point, I'm going to open the forum up to questions that you might have.
Thank you so much, Vivian. I actually have a question. What does patient centralized care mean?
It's going back to what I mentioned, Joyce.
Mm,
It has to be focused on what about that person, what's unique to them. That's what you need to find out. So it's not what you accomplish with them as a patient, but first and foremost, find out what's unique to them. That's where you're going to develop that relationship of trust.
okay, thank you. And how do you work to convince a person with cognitive decline to start the therapy process? Like how can you advise us on that?
Oh, that's really a great question because it's like that. I don't know if you've all seen that movie, 50 First Dates.
Yes.
It's exactly like that. Every time is going to be the first time.
Mm,
Don't rely on the fact that they liked you the day before. Every day is you're going in and you're greeting them,
mhm,
pausing, you're smiling, you're asking for their name, you're telling them who you are, how nice it is for them to meet you, compliment them about something, as I mentioned, about them.
mm,
Um, and the next step is to invite them.
mm,
Can you, whatever you want them to do, invite them? Can you sit down? Can you, whatever it is, you always want to invite them, not do it, not tell them, but invite them.
I see.
And everything then requires a stop and a praise, a stop and a praise. And then as you continue, it's about how about trying? You're asking them the question. How about trying? Um,
Mm,
so
that's important to have. It kind of goes along with that centralized care. Oh, hey, Patty.
Hi, there is a question in the chat, and can you tell us some ways to calm patients down when they get restless, angry, verbally abusive, tired, etc.?
the first thing, good question, Patty. Thank you. The first thing is to acknowledge you seem tired. You seem agitated. I'm so sorry, that you're feeling that way. You need to acknowledge how they're feeling and tell them that you are sorry about that. Stay with the feeling. You're not going to be able to do anything if you don't join with how they're feeling. Don't get physically close in their space. Keep a distance from them. Again, ask if you could sit down. We'll stop now. Could I just sit down? Ask them if they want something. Would they like a glass of water? You need to take a pause. You might be able to continue and you might not be able to continue. But when you're dealing with somebody, and I think we could all identify with that with ourselves, if we get agitated, don't tell me not to be agitated, that's not going to work. Don't tell me things will be okay, because I'm not feeling okay right now. And I can't project into the future because I have dementia. So be with them in that moment, reassure them, stop, pause, don't get too close into their space. Again, ask them, could I sit down? Have a little pause.
Great. Thank you so much.
Oh, I have a question. How does one deal with a patient that is going or undergoing physical therapy, does not recall what exercises they are working on? Any advice for the PT that is struggling to create a building block for their patient?
Yes. Again, I've said this, but always assume that they won't remember that you have been there, who you are, what you're doing. That's 51st dates again. So always start fresh and very positive, very welcoming, like almost like they're your best friend and you're so happy to see them. Join with them. Always introduce yourself. I am Vivian, and I'm a dementia specialist. I'm here because I heard that you have some pain, and I'm showing pain in your shoulder. Um, Really, I'm sorry to hear that. Is it your left? Can you raise your shoulder a tiny, tiny bit? Does that hurt? You're going to take your time, and that's the process. So, if they're undergoing PT and they don't recall, every time is like the first time. You have to introduce yourself, have them introduce you. You can't discuss specifically that is physical therapy and what the benefits are going to be and why you're going to do it. It's not going to make any sense. They're not going to comprehend. They won't be able to interpret. So I hope what I just said makes sense to you.
It
Can I
does.
ask a question? Sorry.
Go ahead.
First, I want to say, Vivian, that was excellent. I learned so much from you today. So thank you so much for speaking, and thank you, artists, for putting this on. I do have a question. Just recently, we had an aid-in with one of our patients who has dementia. We don't know what type of dementia, but she was very violent and very agitated and would go to hit and kick and scratch. I'm curious, how would you handle that? What is, like she would call and ask, what do I do? How do we handle that without treating them like a child, not demeaning them, saying, oh, don't do that, treating them as a child, keeping them respectfully, trying to get them not to hit, scratch, and kick?
It's a good question, Anne. There's always a trigger, Anne.
Yeah.
There is always a trigger, and it requires who's ever providing the care to figure out what the trigger is. It might have been that they were too physically close. Maybe they didn't do the step-by-step direction. Maybe it was too confusing for the person. Maybe they don't understand why they need to take a shower, because they would know when they need to take a shower. So don't tell me to take a shower. There can be a variety of reasons, but most importantly, there is always a trigger to that kind of response. It's a fight or flight.
Right.
So they're going to fight you. But it's getting to know that person. Is it requesting something that they don't understand? Is it something that they don't see the purpose of? And could it be something physically going on? Are they feeling uncomfortable? Are they constipated? Are they feeling hungry? Are they feeling hot? Are they feeling cold? Are they having a headache? but they can't report to you because of their dementia that they have pain and where the pain is located.
Okay, so you
So-
suggest kind of taking a step back and trying to figure out what's going on rather than, the son was in the room and he started yelling at his mom, "Don't hit, what's wrong with you? Why would you do that?" I'm thinking, oh no, that just made her worse and then made her start crying and getting more upset.
I mean, I understand the son, he was probably, paying for your services, embarrassed with how his mother's reaction, feeling that he's going to lose the aid, and he lost it, which
Right.
listen, I get it. I get why he reacted that way. But from the perspective of the person who didn't understand why what the person with dementia isn't really understanding what the trigger is. She can't, or he can't, she can't tell, in this case, she can't tell you what's bothering her, what's making her fearful.
Right.
Can't
Okay.
do it, doesn't have the capacity anymore to do that. So it requires the outsider to be like the Sherlock Holmes and
Mhm.
figure out what the trigger is. And that's not easy. It's not easy.
Okay. Thank you.
You're welcome.
Any other questions? Thank you, Vivian, for this informative presentation. The artist, this is right in line, everything that we have discussed today with the artist way. And I've just heard so much about how we treasure each of our residents' uniqueness and individuality with our care and it is definitely in sync with understanding who these individuals are and being able to create a care plan. So, everyone, Patty and I, thank you so much for being on the call today. We know it's in the middle of day work day, but we are recording, so we'll be sharing this with those who could not make it. But our purpose is to connect with each of our residents and relate to them. But we also, Patty and I, see the importance of connecting with you all who are on the call, and being a really great, positive professional partner and a resource to you all. So I'm very happy I know some of you are familiar with our website and have been on our website. And I wanted to share that we do have that link right up there on our top of our page, our homepage, that says referrals. You'll see it highlighted in red or circled in red. And this is another way that we could connect with you. Everyone has my cell phone and my email, and we have had some conversations already over the holidays. So, but this is another way. So if it's easier for you to go right on our website, and there's a quick and easy referral process. It's a user-friendly submission form, and it will come directly to us. So if this is just another way for us to help our clients and our residents with these struggles that they're facing. I want to talk about what's coming up next. We're having our happy hour, and Patty and I, we love to, yes, I know, and we are going to be doing some trivia, and I have a really fun scavenger hunt that we're going to be doing. We're going to break up in rooms. We're going to use Zoom, and we're going to take a little scavenger hunt around wherever we are. So whether that be your home or your office, it's going to be lots of fun. And that is the 28th on Thursday evening at 7:00. And so Patty and I are excited to see you there and have some fun and get to know each other and celebrate this 2021. And of course, here's my information. I am the Director of Community Relations here for Artists Senior Living in Chestnut Ridge. And Patty Pelican, my partner, my mate, she's right over here helping us today at the back end. She's the Director of Marketing, and her information is there. And we'd like to thank Rebecca Lapel, our Executive Director, for giving us this platform today. So happy Thursday, everyone. And you will be getting a recording of this and Vivian's information as well. So you can always reach out to Vivian directly. And Vivian, thank you so much again we appreciate all that you do.
Yeah, thank you so much. This was great. What time is the happy hour?
It's 7 p.m.
Oh, good.
And I'm
that's
gonna,
good.
yep, and I'm gonna start getting everybody invited to that, and we're gonna be signing up. All right.
Excellent.
Mm-hmm.
Thank you so much again for today. That was such great information, Vivian.
Thank you.
Yes. And I know I will continue helping with I know I think I have an idea of what family you were referring to. So you know I'm always here to help with that family. Mm-hmm.
Thank you.
You're welcome.
And
All right,
anything
guys.
you can do for the dementia community, please don't hesitate to reach out to
Yes.
me. It's really, we need to help this community.
Yes,
So
we
thank
do.
you.
We really do. We're the soldiers for those who are struggling.
Bye, everybody.
Bye. Have a great day and a wonderful
You
weekend.
too.
Bye-bye.